This is case study number 5, adult trauma. Date of the patient contact was April 10th. Unit Charlie 1, shift 12 to midnight, Queens ER disposition, and my preceptor was Alex Berardo, MICT. Dispatch reference was fall case. Scene presentation. Upon arrival, the patient was 81-year-old male in the seated position in his apartment on the floor, leaning up against a wall. The patient is alert and oriented ×3, speaking in full sentences, tracking well. Patient is wearing a shirt soaked in blood and has dried blood covering part of his forehead and his left cheek. The patient states he has been sitting here for a couple of hours. The patient states he lost his balance and hit his head on the desk corner as he fell. Chief complaint is fall. Pre-hospital assessment. AVPU assessment. The patient is alert and responsive to verbal stimuli. OPQRST, part of the assessment. Onset, the patient states loss of balance was sudden, and he denies any stroke-like symptoms, seizures, loss of consciousness, dizziness, paresthesia, or other neurological deficits leading up to the event. The patient's pain is localized to laceration on the left side of the scalp at the forehead and hairline. Is not touching the laceration. Not touching the laceration makes the pain better. Q quality. The patient states the pain feels like a throbbing and sharp type of pain. Patient denies any radiating pain. States the pain is about a 2 out of 10 when no one's touching it. And the pain began immediately following the incident. Since the patient's fall was unwitnessed, the patient required C-spine board despite denying any C-spine or midline back pain. On-scene vital signs were conducted, including blood pressure, pulse, respiratory rate, 3-lead ECG, and blood glucose. The patient's heart was monitored with a 12-lead EKG en route to disposition, and since the patient was stable, the vital signs, physical exam, and CMS were reassessed en route every 15 minutes. The patient was displayed no neurological deficits and was alert and oriented ×3 upon arrival at Queens ER. Medical history. The patient states he has no allergies to food, medications, or other substances. Medications. The patient says he is taking medications for high blood pressure and depression. The patient is adhering to medical direction for the consumption of his medication. The patient states he had a stroke 10 years ago, 10 years prior to the event today, but has not experienced any serious medical complications as a result, other than some loss of walking mobility and balance. The patient believes he did not have a stroke today and denies loss of consciousness. The last oral intake for the patient was breakfast this morning of oatmeal and juice. He has not been drinking all that much water. The patient states he had a normal day today, unremarkable events prior. He just walked with his walker around his apartment and has a difficult time often walking between the bathroom and the living room. For the treatment summary, the patient's on-scene treatment included assessment, the initial assessment, and vital signs, as well as the 3-lead ECG. After the patient was secured to the C-spine backboard, we immediately took him to the ambulance for transport. Transport en route, 3-lead EKG was administered, 12-lead as well. Vital signs and physical exam were reassessed every 15 minutes, and an IV bolus was administered. The admitting diagnosis or physician's impression was a superficial head trauma, possible intracerebral hemorrhage and skull fractures, although unlikely. So the ER floor treatment, the patient was treated by the ER floor staff and bandaged up, and a CT scan was conducted to check for intracerebral hemorrhage and skull fractures. Following up with the patient, the follow-up with the patient revealed no intracerebral hemorrhage or skull fractures. The patient's trauma was localized to the superficial layers of the skin on the upper left side of the skull and head, which caused him to bleed profusely since that area is saturated with capillaries. So in describing my feelings, observations, and reactions with regard to technical performance, interaction with patients and other EMS members and personnel of the hospital, Since my initial assessment of the patient revealed him to be alert and oriented ×3, and that he did not appear to be in immediate distress, I focused primarily on collecting accurate vital signs and relaying that information to the medic. I was worried for him at first that the injury was deeper than he perceived it to be, and that he was in a sort of shock or delirium from being on the floor for so long. However, as the patient was mentally sharp and this anxiety in me kind of faded, and I had a feeling that he was going to be fine after getting cleaned up at the hospital. So this was a good opportunity for me to practice my vital signs, IV, C-spine, and lifting and moving skills, as well as to practice bedside manner and help keep the patient focused on other topics than the laceration on his head and the bleeding, which had stopped at that point. A comprehensive pathophysiological review. So the most important thing EMS providers can do for their patients is to help them perfuse. Perfusion is the adequate supply of blood, which carries with it all the necessary nutrients and chemicals which make life possible. Aerobic metabolism is not possible without proper perfusion of oxygen molecules and efficient removal of CO2 and other waste products. If a disruption to perfusion is encountered, either by a lack of available oxygen in the blood or by a decrease in blood pressure by active bleeding, anaerobic metabolism will begin to cause cellular death as a result of the buildup of CO2, lactic acid, and other toxins. Bleeding and soft tissue trauma is a crucial area of study of which an EMS provider must be proficient. If initial assessment of the patient reveals active bleeding, immediate actions must be taken to stop the bleeding and allow the patient to begin perfusing properly again. Bleeding can be encountered in any number of different circumstances and severities. Arterial bleeding is the most serious type of bleeding, as arteries are directly tied to the pressurized side of the body's vasculature and carry the vast majority of the blood's nutrients intended for cellular metabolism. Arterial bleeding can be distinguished from venous bleeding by its bright red color resulting from O2 saturated hemoglobin in red blood cells and a spurting or pulsating type of flow. Venous bleeding is serious as well and must be stopped, but may not as quickly cause hypoxia and cellular death. Venous bleeding is distinguished by its darker red color and slow, steady type of flow. Bleeding from the capillaries only is the least serious form of traumatic bleeding and results mostly from minor abrasions and superficial layers of the skin. Direct pressure must be used as the first method of stopping active bleeding of any kind. Should the bleeding be unable to be controlled by this method, a tourniquet may be used to clamp off the blood supply. Topical hemostatic agents may be used as well as a temporary means of controlling active bleeding. Bleeding from the head or face may be indicative of severe trauma deeper in the patient's skull and must be taken seriously. If a patient loses enough blood, he may go into hemorrhagic shock, which is the body's inability to adequately perfuse its cells with oxygenated glucose-saturated blood due to a significant loss of blood volume, either internally or externally. Inadequate perfusion to the brain is a serious condition which results in cellular hypoxia and death. And my reference for this is the pre-hospital medical textbook and chapter 28, Bleeding and Soft Tissue Trauma.